This integrative presentation is focused on pain. Please read the information in your textbook. Pain is defined by Geach in 1987 is, quote, the noxious stimulation of threatened or actual tissue damage, end quote. It is known that pain is highly subjective and individual, and it is of the body's defense mechanisms indicating that there is a problem. Again, it is one of the body's defense mechanisms indicating that there is a problem. Pain may be described as bodily or mental suffering or distress, agony, or anguish. It is known to be the most common reason people seek help from a physician. It is a highly unpleasant and very personal sensation that cannot be shared with others. It is more than a symptom of a problem. It is a high priority problem in itself. Pain presents both physiologic and psychological dangers to one's health and recovery. Origins and causes of pain. Number 1, cutaneous pain originates in the skin or subcutaneous tissue, such as from a paper cut. Deep somatic pain arises from ligaments, tendons, bones, blood vessels, and nerves. It is diffuse and tends to last longer than cutaneous pain. Example, sprained ankle. Visceral pain results from stimulation of pain receptors in the abdominal cavity, cranium, and thorax. It is caused by stretching of the tissue, ischemia, or muscle spasms, and it is described as burning, aching, or a feeling of pressure. Emotional pain is pain that can have a physical cause or a psychological cause. A physical cause cannot be identified when it's emotional. Types of pain. Pain can be described as acute or chronic based on its duration and intensity. Acute pain may have a sudden or slow onset. It varies from mild to severe and may last up to 6 months and subsides as healing takes place. Chronic pain lasts 6 months or longer and often limits normal functioning of the individual. Radiating pain is perceived at the source of the pain and extends to nearby tissues. Example, cardiac pain may not only be felt in the chest, but along the left shoulder and down the arm. Continuing with types of pain. Referred pain is pain felt in a part of the body that is considerably removed from the tissue causing the pain. For example, pain from one part of the abdominal viscera may be perceived in one area of the skin remote from the organ causing the pain. Intractable pain is pain that is highly resistant to relief. Example, pain from advanced malignancy. Phantom pain is a painful sensation perceived in a missing body part, such as an amputated leg, or in body part paralyzed from a spinal cord injury. Chronic malignant pain is pain associated with cancer or some other progressive disease. Chronic non-malignant pain is pain associated with tissue injury that is non-progressive or healed. Chronic malignant pain is associated, we've repeated this before. This is a repeat. Common sites of referred pain include, the illustration is shown here. You can see, heard the definition of referred pain, and it can be found to have started in one area of the body and be felt in another region as well. The McGill Pain Questionnaire is a questionnaire used to assess one's pain, such as the onset, quality, location, duration, etc. I'm sure you have a pain questionnaire source in your textbook. Please refer to what resources you do have, as well as look at the referred pain site information in your text. Please read this slide that focuses on common pain myths, misconceptions, and facts as it relates to pain. Comparison of acute and chronic pain. Acute pain is mild to severe. Sympathetic nervous system responses occur, which include an increased pulse rate, dilated pupils, is related to tissue injury. Client reports the experience of pain, and the client exhibits behavior indicative of pain, which include crying, increased respiratory rate, elevated blood pressure, and diaphoresis. Chronic pain is associated with also being mild to severe, and you have the parasympathetic nervous system responses, which include normal vital signs, dry, warm skin, pupils normal or dilated. The pain continues beyond healing. Client appears depressed and withdrawn. Client often does not mention pain unless asked about the pain, and pain behavior is often absent. Pain perception across the lifespan. Pain perception is the point at which the person becomes aware of pain. In infants, they perceive pain, respond to pain with increased sensitivity. Older infants try to avoid pain. For example, turns away from the pain source and physically resist. Toddler preschooler may consider pain a punishment, feel sad, may learn there are gender differences in pain expression. They tend to hold someone responsible for pain. The school-age child tries to be brave when facing pain, can usually identify the location and describe pain. With persistent pain, they may regress to an earlier stage of development. In adolescence, they may be slow to acknowledge that they are in pain. Recognizing pain or giving in may be considered a sign of weakness. Want to appear brave in front of peers and not report pain. Adults may ignore pain because to admit it, it is perceived as a sign of weakness or failure. May use pain for secondary gain. For example, to get attention. Fear of what pain means may prevent some adults from taking action. In the older adult, they may see pain as part of the aging process, may have decreased sensations or perceptions of the pain, may withhold complaints of pain because of fear of the treatment. of any lifestyle changes that may be involved, or of becoming dependent. They may consider it unacceptable to admit or show pain. Pain threshold and pain tolerance. An individual's pain threshold is the amount of pain stimulation a person requires in order to feel pain. Intense sensitivity to pain is called hyperalgesia. Pain tolerance is the maximum amount and duration of pain that an individual is willing to endure. Some clients are unable to tolerate even the slightest pain, whereas others are willing to endure severe pain rather than be treated for it. Pain tolerance appears to increase with age. Pain sensation can be considered the same as pain threshold. Pain reaction includes the autonomic nervous system and behavioral responses to pain. The behavioral response is a learned response used as a method of coping with pain. Again, the behavioral response is a learned response used as a method of coping with pain. Gate control theory. According to gate control theory, peripheral nerve fibers carrying pain to the spinal cord can have their input modified at the spinal cord level before transmission to the brain. Synapses in the dorsal horns act as gates that close to impulses from reaching the brain or open to permit impulses to the brain. Small diameter nerve fibers carry pain stimuli through the gate, but large diameter nerve fibers going through the same gate can inhibit the transmission of those pain impulses. That is, close the gate. The gate control theory has led to the recognition that pain can be reduced or modulated at 4 points. A. The peripheral site of pain. B. The spinal cord. C. The brain stem. And lastly, the cerebral cortex. Psychosocial/cultural factors that affect the perception of pain is the next focus. In some cultures, pain may be considered a punishment for bad deeds. The individual is, therefore, to tolerate the pain without complaint in order to atone for sins. Age. As previously discussed, age is an important variable that influences how people admit or describe pain and how they behave. Environment and support persons. A strange environment, such as a hospital with noises, lights, and activity, can compound pain. The lonely person who is without a support network may perceive pain as severe, whereas a person who has support people around may not perceive the pain as great. The Loesch model of pain assessment. The Loesch model suggests that you consider 4 factors when assessing pain: the nociception, the pain, the suffering, and the pain behavior are to be assessed. Nociception is a peripheral event. When assessing for nociception, think in terms of tissue damage that has activated the nervous system. You're looking for actual or potential tissue damage from thermal and mechanism or mechanical causes of pain. Pain as a result of nociception, noxious stimuli are transmitted to the central nervous system. The patient feels pain. The patient states that they are in pain. It's subjective. Increased heart rate, respiratory rate, blood pressure, diaphoresis, and dilated pupil are objective findings. Continuing with pain assessment, suffering is the emotional impact of pain. Suffering is difficult to describe, so people usually speak in terms of pain. People show suffering in many ways. They include anxiety, fear, anger, depression, and stoic endurance. The nurse must assess how the pain is affecting the client emotionally. Pain behavior is a measurable response to pain. It is the client's way of telling you he or she is experiencing pain. Pain behavior is shaped by personality, background, culture, and social factors. Pain behavior changes with time as pain gets better. Behaviors change. Pain behavior allows the nurse to measure the effectiveness of nursing interventions. As a part of doing the pain assessment, you want to look at the pain history. Information includes obtaining the location of the pain, extension or radiation, onset and duration patterns, character or quality, precipitating, aggravating, and alleviating factors, intensity, associated symptoms, effects on activities of daily living, and methods of pain relief. Pain scale. I want you to identify what type of pain scale this is. It can be used for individuals who cannot read. Pharmacologic pain management, and let me repeat that there are different pain scale tools available. Please reference your book. Now we will look at pharmacologic pain management. Opiates or narcotic analgesics include opium derivatives such as morphine sulfate and codeine. Narcotics relieve pain and provide a sense of euphoria largely by binding to opiate receptor and activating endogenous pain suppression in the central nervous system. There are two primary types of opiates. You have full agonist and mixed agonist antagonist opiates. Full agonists include pure opiates that bind tightly to receptor sites, producing maximum pain inhibition. These include morphine sulfate, codeine, Demerol, Darvon, and Dilaudid. Mixed antagonist analgesics act like opiates and relieve pain, the agonist effect, when given to the client who has not taken any pure opiates. They can block or inactivate other opiates when given to a client who has been taking pure opiates, which are antagonists. These drugs include Talwin, Duponex, and Stadol. Opiates may cause nausea, vomiting, constipation, and respiratory depression. If the client experiences significant respiratory depression, in which the respiratory rate drops from 18 to 12 or is overly sedated, the dose was excessive. Give Narcan. Before administering narcotics, the nurse needs to assess the client's vital signs and level of alertness for baseline data. And you also need to ask about history of allergies to medications. Non-opiate, non-steroidal anti-inflammatory drugs. They include non-steroidal anti-inflammatory drug examples: aspirin, acetaminophen, and ibuprofen. These medications relieve pain by acting on peripheral nerve endings at the injury site and decreasing the level of inflammatory mediators generated at the site of injury. Most common side effects of non-opiate, non-steroidal anti-inflammatory drugs is indigestion. You need to take the medications with antacids or food. Non-steroidal anti-inflammatory drugs are contraindicated in patients with impaired clotting, GI bleeding or ulcer risk, renal disorders, and possibly infections, because non-steroidal anti-inflammatory drugs will obscure fever. Routes for opiate delivery: they can be administered orally, transdermal through the use of a skin patch, subcutaneously, intramuscularly, intravenously, intraspinal or epidural route. Next focus for administration: patient controlled analgesia or PCA pumps. PCA is the self-administration of an analgesic by a client properly instructed to do so or to give the medication. The client controls the analgesic dose within safety limits set by the physician. PCA enables the client to administer analgesics safely when they need them. Benefits include self-control over pain, lack of dependence on the nurse to provide pain relief, stable analgesic blood levels to provide continuous pain relief, tendency for the client to need less medication, and as is indicated, the healthcare provider will identify how much medication the patient can be given by PCA, the lockout time that can be administered also when they can't get the medication. Non-pharmacologic pain management measures: it consists of a variety of physical and cognitive behavioral pain management strategies. Physical interventions include cutaneous stimulation, immobilization, transcutaneous electrical stimulation, also known as TENS, acupuncture, and administration of placebos. Cutaneous stimulation provides effective temporary pain relief. It distracts the client and focuses attention on the tactile stimulation, away from the painful sensations, thus reducing pain perception. Cutaneous stimulation includes massage, application of cold or heat, acupuncture, and contralateral stimulation, stimulating the skin in an area opposite to the pain source. TENS units and placebos. TENS is a non-invasive, non-analgesic pain control technique that allows the client to assist in the management of acute and chronic pain. Cutaneous stimulation from the electronic signals of the TENS unit can activate large diameter fibers to trigger central nervous system to close the gate to signals given to small diameter fibers. A placebo is any form of treatment, such as medication or nursing intervention, that produces an effect in the client because of its intent rather than its physical or chemical properties. Cognitive behavior interventions. The goals of cognitive behavior interventions are to alter pain perception, alter pain behavior, provide clients with greater sense of control over pain. With distraction, you want to draw the client's attention away from the pain and lessen the perception of pain. If you have any questions, please make them known. I will follow up tomorrow after the HESI test to see if those of you in my class or Mr. Rogers' class have any questions. Have a good day, and make sure you read, know your learning objectives, and use the main points in answering. Thank you.